Okay, we're back with part 2. We're going to continue on with the shoulder girdle. And what we're going to do here is we're going to start by looking at the lat length. It's going to also look at some of the pec musculature and just general joint health in the joints that make up the shoulder joints. We're not just talking about the shoulder, but we're going to, in order to have healthy overhead motion, you have movement of several joints. The sternoclavicular joint, the AC joint, of course the glenohumeral joint or the shoulder joint, and then we've got the scapular-thoracic joint, which isn't really a joint, it's more of an articulation just between the shoulder blade and the rib cage and the thoracic spine. So to really kind of see what's going on with his lats and his pecs, we're going to have him flex his legs so that they're up in the air like this. And what that's going to do is it's going to flatten out his back a little bit. You feel like your back's pretty flat. And the lat's a pretty big muscle. It's really the biggest muscle in the human body, but it goes from the humerus onto the rib cage, onto the spine, all the way down to the pelvis and the iliac crest and the thoracolumbar fascia. So if we were to allow him to keep his legs down or even straight, as he lifts his arms up, that tension in the lats and in that fascia can pull him into extension, which is basically kind of avoiding the stretch. So it could show us that he has good range of motion in shoulder flexion, and in reality he does not. So we can just take that out, take that slack out by bringing these up. And then what I'm going to have you do is just put your hands straight up towards the ceiling. If someone was a little irritable in the shoulders, maybe if you knew before, we maybe wouldn't want to have them in this pronated position. We'll take them in like a sort of a neutral or semi-supinated position. So let's try from there. And then all you're going to have them do is just try to bring their arms back as far as they can towards the table. Okay, and making sure that that back's staying flat. And he can get his arms back. You see his elbows bend a little bit here. Brett's a pretty big guy. He does a lot of strength training. He's got a lot of muscles, so some of this could just be some passive muscle stiffness. But, you know, I'm not seeing anything like this. I'd be very alarmed with that. He's able to get down. The fact that they do go out a little bit tells you that there probably is a little lat or a little teres major muscle. Those are the two primary internal rotator muscles that we're testing here. We're also going to be looking a little bit at the subscap in this position, pec minor and the pectoralis major muscles. If you don't know what those muscles are, just look them up. So, one, we're seeing if we can get close to the table without coming out too far, and we're also seeing if there's a big asymmetry. Like if he's got one arm like that and one arm like this, we know that's a problem. He's definitely not going to probably get a lot of good results out of doing a barbell press overhead when one of his shoulders only wants to go this far and the other one will go like this. But he's pretty symmetrically mildly tight, which is what we would expect to see. And then from there, what we can have him do is interlock your fingers, put them behind your head, and we'll start with the elbows up in the air. And we're going to do the same thing here. We're just going to keep these up and go ahead and just let gravity take these and open that up. And what we're looking for here is for him to be totally relaxed and see if we can get the arms just flush with the table. He can do that. So that's indicative of fairly good range of motion or extensibility in the pectoralis major. If it was tight, say on this side or both, you'd see something like this. You'd see them up, and you're going to see this in a lot of trainees, especially male trainees, and people who have done a lot of sort of beach muscle work, is you're going to see this, or people who sit at a computer a lot, which is very, very common these days. So he's actually doing pretty well there. From there, we'll go ahead and put the arms straight down by the side. I'll go ahead and let you just put your feet there, but keep them bent there at the knee, because the pec minor doesn't have too big of an influence, and that's what we're looking at here, is see what's going on with the pectoralis minor length. And what we want to see is we want to see kind of the difference between the acromions, which is sort of the knobby bone at the very top of the shoulder, and the table. And if there's a big difference, if this was really tight, you'd see something like this. Go ahead and kind of protract that shoulder up. It'd be like that. That's called a protracted shoulder girdle, and that's very indicative of some tightness here in this pectoralis minor. But he's doing all right there, so I'm okay with that. And I'm not seeing a really big difference there in his in those muscles. From here, we can get a little bit more into the glenohumeral joint, and we're going to look at external rotation. So if you slide the arm out just to where the humerus is kind of even with his collarbone, so we don't want to bring it up above 90, just to about 90. And then it's kind of a good idea to just put a little bit of pressure on the front of the shoulder. Some people have a very lax anterior capsule, and maybe they didn't know it, but if they had some sort of a problem and you just jack their arm back into external rotation, it might cause some pain or potentially a dislocation if you did it hard enough. So we're just going to put mild pressure there, and I'm just going to sort of see where this will go. And we'd like to get this to about parallel, and he's able to do that, so that's good. If you're dealing with a throwing athlete on their throwing arm, you might find this thing way below the table. That's not uncommon because of the torque that's happened over years of throwing, which can be a little alarming. And what you're going to see then is a very limited internal rotation, which we'll test next. So now I'm back to neutral. I stabilize the shoulder, and we try to let this fall into internal. It's typically a little bit tighter this way. You're not going to go maybe to parallel, but you want to get close to parallel from this position here. And that's not bad. That feels like a pretty decent range of motion there. And now we're going to check this side though, because really what we're looking for is the difference here. So we'll come over to this side here. We abduct the humerus, the shoulder, right here to about 90 degrees. Same thing here. I'm going to stabilize, and we're just going to let gravity take this down, and it's about what we got on the other side. And there's something you can look for called end feel if you're licensed to be able to sort of assess people. We're not diagnosing here, but we're just trying to see is how springy is it at the very end. Is it real hard, or is it a little springy? He's got a pretty good spring there, so it feels pretty good. And of course, with any of these, you're looking if there's any pain. Was there any pain in any of these? No pain, so that's good. So we did the external rotation, which is testing the internal rotator subscapularis muscle, which is one of the 4 rotator cuff muscles. It's on the anterior shoulder blade, the subscapularis. Very important muscle for sort of holding the shoulder into the joint, especially as you elevate the arm. It kind of sort of sucks it into the joint there. And then we're going to stabilize. We're going to come down. Ooh, is this your dominant arm? Okay, so this is Brett's dominant arm, right-handed. You can see there's a significant difference here in internal rotation. That's not uncommon with a dominant hand. But the fact that he can't get this one back really, really far tells me that he's lost internal rotation. And that could also be a thoracic spine problem. In the functional movement screen system, a lot of shoulder girdle tightness seems to be kind of masquerading as thoracic spine or rib cage dysfunction. So that could be something that's a little more beyond the kind of the expertise of a trainer. But it would definitely be something that you'd want to at least check out, and if possible or if necessary, you would refer out if there's any kind of pain or any kind of dysfunction. If the range of motions are a little asymmetrical, you'd like to even those out. You might not get them perfect, but you want to at least identify and know that was there. And we'll be back with some assessments for the lower body.